72-year-old woman has 2 days of abdominal pain, distension and vomiting after not opening her bowels for 10 days. She has osteoarthritis, managed with codeine, and had a cholecystectomy 2 months ago. She has a distended tympanic abdomen with hyperactive bowel sounds. The figure shows an abdominal X-ray is included in the picture. Which is the most likely diagnosis? A. Large bowel obstruction. B. Paralytic ileus. C. Sigmoid volvulus. D. Small bowel obstruction. And E. Toxic megacolon. So pause the video here and give yourself about 30 seconds to go through the correct answer. So the correct answer is D. Small bowel obstruction. And we'll go through why in the following slides. A bowel obstruction describes the functional or mechanical obstruction to passage of bowel contents through the bowel. A small bowel obstruction, as seen in this case, describes an obstruction between the duodenum and the ileum, and a large bowel obstruction describes an obstruction of the colon. A functional obstruction, otherwise known as a paralytic ileus, relates to ineffective or absent peristalsis, where the lumen of the bowel is not physically obstructed. However, there is a functional obstruction of passage of bowel contents. Further classifications include partial, which relates to incomplete obstruction, which may resolve with conservative measures, and complete, which describes a complete luminal obstruction with failure to pass flatus or stool. This is often associated with peritonitic features such as guarding, rigidity, and rebound tenderness, and this is a surgical emergency as there is a risk of perforation. A simple bowel obstruction describes an intestinal obstruction in the absence of peritonitis, which may respond to conservative measures. And a complicated bowel obstruction describes a bowel obstruction complicated by necrosis of bowel contents with intestinal ischemia plus or minus perforation. This is a surgical emergency requiring urgent resuscitation and surgical resection of necrotic bowel. Risk factors for bowel obstruction include adhesions relating to previous intra-abdominal surgery, hernias, which can lead to herniation of the bowel content into a defect into the abdominal wall, leading to obstruction, inflammatory bowel disease such as Crohn's disease, which can lead to strictures of the bowel, intestinal malignancy, which more typically relates to large bowel obstruction, and appendicitis. If there is a significantly dilated inflamed appendix, this can cause compression and bowel obstruction. The pathophysiology of bowel obstruction describes a disruption in intestinal patency with proximal dilation of the intestines, leading to hyperperistalsis as the bowel goes into overactivity, working to push the luminal contents past the obstruction, producing severe abdominal pain, absolute constipation and vomiting, with progressive decreased arterial perfusion leading to bowel ischemia, necrosis and perforation. Symptoms of bowel obstruction include constipation with a failure to pass flatus and stool, abdominal pain and distension, vomiting, a palpable abdominal mass, and peritonitic features mentioned previously, including a distended tympanic abdomen with hyperresonance to percussion and rebound tenderness. In such severe cases, they may also be associated hemodynamic instability. Appropriate investigations for bowel obstruction include a full set of bloods, including full blood count, USANEs, LFTs, pancreatic enzymes, CRP, and ABG to look for lactate. A raised lactate suggests ischemia of bowel tissue, and clotting and group and save to prepare for surgery. A CT abdomen should be performed, which demonstrates large dilated loops of bowel and air fluid levels, and there may be an identifiable transition point which locates the location of obstruction. The approach to bowel obstruction is provided as an overview in this flowchart. In patients with clinical features consistent with bowel obstruction, an A to E assessment should be performed and immediate conservative measures implemented, colloquially described as drip and suck, and the patient should be made nil by mouth with an NG tube replacement to proximally decompress stomach contents and reduce pressure on the bowel, and intravenous fluids to replace intra-abdominal losses. Further supportive measures include analgesia, antiemetics, oxygen as required, and antibiotics if there is evidence of associated superimposed infection. Imaging studies should be performed. In a stable patient, it is appropriate to obtain a CT abdomen, as this is the most accurate and gold standard imaging to diagnose both bowel obstruction and the location and characterization of pathology. But in the unstable emergent setting, an abdominal X-ray or an ultrasound can be performed. If there are findings suggestive of bowel obstruction, such as proximal bowel dilation, multiple air fluid levels, and bowel wall thickening, an urgent surgical consult is advised. The patient should also be assessed for any complications such as perforation, ischemia, or closed loop obstruction, which are surgical emergencies. Subsequent steps should then be taken to relieve the obstruction. In a partial obstruction or a paralytic ileus, it is appropriate to follow conservative measures, so continue with drip and suck, as this will most likely resolve the bowel obstruction. In the uncomplicated obstruction, or any sigmoid volvula, so evidence of volvulus on abdominal imaging, endoscopic decompression such as a sigmoidoscopy or insertion of a flatus tube can be considered. And if there is failure of either of these two measures, you should proceed to the management for a complicated obstruction, which describes an urgent laparotomy involving the treatment of the obstruction, resection of any necrotic bowel formation, and stoma formation if required. So going back to our clinical scenario, we can see the features in this stem consistent with diagnosis of bowel obstruction include abdominal pain, distension, and vomiting after a prolonged period of obstipation. Osteoarthritis managed with opioid analgesics is a risk factor for constipation and subsequent bowel obstruction, and a cholecystectomy 2 months ago suggests there may be intra-abdominal adhesions. The presence of a distended tympanic abdomen with hyperactive bowel sounds is in keeping with a diagnosis of bowel obstruction. The figure, we can see an abdominal X-ray which shows gross dilation of the small bowel, and you can tell it's a small bowel as the valvular coniventes traverse the full width of the bowel. All of this is in keeping with a diagnosis of bowel obstruction.